Good morning, students. Hopefully you're having a good break, even though it's only one day. This is Chapter 12, Ventilation, Perfusion Relationships, and Arterial Blood Gases in Module 8. Okay, so let's talk about perfusion for just a minute. All right, perfusion is the amount of blood flow that's going past the alveoli or past an area of the body. We usually refer to perfusion relationships in the lung, of course, as how much blood is passing from the right side of the heart to the left side of the heart as it passes through the capillary area just at the alveolar level. The alveoli here represents sort of the cluster of one unit. Keep in mind that alveolar ventilation is how we determine how much air we get into our lungs, and we've talked about that in previous chapters. So when we get ventilation over perfusion, we get a ventilation-perfusion matching. That normal matching is approximately 0.8 if you did it by percentage. So look here, we have 4 liters of ventilation on average. We have for ventilation, and for perfusion we have 5 liters. If you take 4 divided by 5, that means 80% of what we breathe compared to how much blood flows past is a normal ratio that we should be looking for. If this ratio goes up or down, then that's usually a consequence of some pathology. All right, so in the upright lung, gravity takes has the most impact on 2 areas. One is the base, which results in a higher blood flow, and that's down here at the bottom. So as ventilation or perfusion increases down here, the ratio of ventilation to perfusion decreases. The other part is at the top, where we have a lot more ventilation and less perfusion, again because of gravity. So the reason we have a higher VQ, ventilation, in the upper lung is because of gravity. Gravity pulls blood flow to the base. Well, that means that the base has more perfusion than it does ventilation, so therefore the VQ ratio goes down. In the middle of the lung, it's just about equal. So where you see the greatest effect, so we're in the upper and the lower portion of the lung. All right, so when ventilation ratio is high, it can happen for one of 2 reasons. Either ventilation has increased or perfusion has decreased, or both. So in this case, we have, all right, so high VQ. Both mechanisms cause the alveolar oxygenation to increase. Because we're actually bringing in more air and we have less perfusion in relationship to that, we end up that we have a lot more oxygen that enters the alveolus. And at the same time, when the ventilation or the perfusion is lower than normal, that decreases how much oxygen diffuses. So we can either have dramatic increase in ventilation without any change in perfusion, and that ratio will go up. The other way we can have it is the perfusion goes down with no change in ventilation, and that ratio goes up. Bottom line is this: alveolar pressure increases and alveolar carbon dioxide pressure decreases, and the reason is this: ventilation directly impacts how much CO2 we clear. So if we've got on this side, both mechanisms cause the arterial CO2 to decrease. One of the reasons is because as we breathe deeper and faster, or both, CO2 clears at a faster rate. And then, of course, if blood flow has decreased, that reduces the amount of CO2 returning to the alveoli. And of course, remember that there's an imbalance here for some reason. So could we have ventilation that increases and perfusion that decreases at the same time? Of course, which means that that ventilation-perfusion mismatch can become even greater. But at some point, what's going to happen is that ratio gets too high and the CO2 will begin to increase in the bloodstream. So for example, if you look over here to the right here, high capillary oxygen, low capillary CO2, and high pH. That's up to a point. Once we no longer exchange gas, all of this reverses. CO2 goes up, oxygen level goes down, and pH comes down. Low VQ, under normal circumstances, when ventilation drops, CO2 increases. So let's look at that. Low VQ. That either means that ventilation has dropped or perfusion has increased. One of the two or both. That means ventilation is low. When ventilation is low, two things happen. We don't exchange as much oxygen and we don't clear as much CO2. What's going to happen here? We have a low oxygen level at the capillary bed, which means that what goes to the body is going to be lower. The CO2 is going to be higher because we're not ventilating as much, and then the pH becomes lower. In other words, we have an uncompensated respiratory acidosis with hypoxemia. All right, so if we go back over here, perfusion is high. So if you have a very fast perfusion going past here, same thing can happen as if you have a very low ventilation up here. And the answer is yes, you can have both. We can ventilate, hypoventilate, for example, and have an elevated heart rate, in which case that worsens this problem here very quickly. If you had a choice, of course, this one would be far less beneficial to a patient's overall survival from the previous one. All right, so the oxygen and CO2 diagram. All right, this is really showing the ventilation relationship again, increasing as we go up towards the head and decreases as we go towards the base of the lung. And look what happens here. All right, so if you look at the red line, okay, this blue line represents what happens. Oxygen levels at 100. The VQ ratio is normal. As the ventilation ratio decreases, or increases, excuse me, that means ventilation increases or perfusion decreases. There's an increase in overall oxygenation at the alveolar level. Now this isn't the oxygen that's actually in the bloodstream yet. This is just at the alveolar level. So that kind of makes sense. We're washing out the CO2 and we're increasing the oxygen. So look what your CO2 is at this point. If you come all the way over here, it can get very low. This means that at this point, we are no longer exchanging gas efficiently. This is only at the alveolar level. So ventilation to ratio, perfusion ratio increasing, CO2 drops significantly, oxygen increases, but that doesn't mean we're exchanging all of that gas. We have to look at a blood gas to determine the issue there, how much it's infecting it. But you can guess that if it's very low here, the chances of us getting rid of the CO2 in the bloodstream is going to be low if that is significant. All right, so here's the ventilation perfusion ratio. It's decreasing. That means ventilation is going down or perfusion is going up. As that happens, oxygenation falls and CO2 begins to rise. Now you'll notice that CO2 doesn't begin to rise a whole lot in the alveoli, but keep in mind, when this does happen, the CO2 in the bloodstream will increase more. So it will most likely be a much higher value in the bloodstream. Again, this is alveolar CO2 and alveolar PO2, not what's in the blood. So keep in mind, it is not what's in the blood, so we need to be aware of that when we look at a blood gas. All right, so what happens in the apex? All right, remember in the apex, we have a very high ventilation to perfusion ratio. In the base, we have a low ventilation to perfusion ratio. Look what happens to different areas under the same circumstances, under the same amount of breathing and actual perfusion overall. So when we look at somebody's blood pressure, we're getting an average. But when you do this, we're looking at what happens at these individual spots. So this is the apex and this is the base. Look at the difference in the arterial oxygen here. The alveolar oxygen here and the alveolar oxygen here. That's a 50 millimeter difference. The CO2, again, there's a 16 millimeter difference. So you have a much higher CO2 value in the base and a much lower oxygen level in the base. But keep in mind, what's going to happen here is that not all, but in many cases, let's just assume it does at this point. If all of that gas moves in and then the CO2 moves out, that leaves a capillary CO2 level of 30 and a CO2 level, oxygen level of 130 and 80 and 46 respectively, assuming equilibrium. Well, when you take those gases and mix them together, you get a venous admixture. And that's actually what ends up going to the left heart. So our average, an oxygen level of 100 and a CO2 level of 40. So when this blood mixes from here to here, we get an overall average of 140 respectively. All right, ventilation and ratio and alveolar oxygen and capillary oxygen. All right, the CO2 changes based on lung zone. So again, we have the upper, which is zone 1, middle, zone 2, and then zone 3, which is the lower. Low VQ, remember, in the bottom, and high VQ in the top, and average in the middle. All right, so if we looked at the average, which is what we would consider a normal blood gas, 740, 40, and 100, this is what we would expect to get if we were looking at a normal blood gas, and interpretation would be a normal acid-base balance. All right, so if we use that as our baseline, as we move to the low VQ areas, which is down in the base, we become more acidic, we retain more CO2, and the oxygen level's lower. Okay. As we move to the right of this graph, part of the graph, that means that the ventilation to perfusion ratio is increasing. So what happens? Again, we end up with a lower CO2 and a higher oxygenation level. So the mixture of all of these is going to give us that average between 735 and 745. A CO2 level generally between 35 and 40, or 35 and 45. Even though the CO2 up here shows 30, the range wouldn't be 30 to 46. And of course the oxygen level is normally between 80 and 100. One of the reasons for that difference is that pH doesn't change a lot from the venous to arterial blood. However, oxygen and CO2 do change more, so that's why we end up, if you look at the range here, 80 to 40, or 80 to 100, excuse me, is what the normal oxygen level would be in the bloodstream, and then 40 for the CO2 with the range of 35 to 45, so it actually falls more in the center there. Gas exchange between the systemic capillaries and the cells is internal respiration. So when we have internal respiration, that means we're using oxygen and producing CO2. We consume 250 milliliters of oxygen per minute, and we produce about 200 mLs of CO2. When you take that value for CO2, how much we can produce and how much oxygen we consume, and divide 200 by 250, we get 0.8. Well, it's no coincidence that our ratio, which we call our RQ ratio, or respiratory quotient, equals our ventilation to perfusion ratio. So stop and think about that. Our ventilation and perfusion ratio under normal circumstances should equal our RQ. Now, respiratory exchange ratio. We talked about this a little bit in the previous chapter about how much we actually exchange. This is, again, the amount of oxygen and CO2 exchanged during a period of 1 minute. And remember that there's only about 0.75 seconds that the flow of blood goes past an alveoli, and only about 25%, or a third of that time, or about 0.25 seconds, actually involves any gas exchange. Well, same thing happens at the cellular level. So our respiratory exchange ratio, okay, and RQ, so RR stands for respiratory exchange ratio, and RQ should be equal. How much we're exchanging should equal how much we're consuming and producing. So alveolar oxygen and CO2 pressure will change as a result of VQ ratio. Again, RQ and VQ equal each other under normal circumstances. So a change in that will change how much CO2 and oxygen oxygen we consume and CO2 we produce. All right, so if we look at the normal unit here versus the shunt unit versus the dead space unit. Now, probably need to talk a little bit about those terms. One, shunt, where you have blood flow but less ventilation. Whereas with dead space, you have no blood flow or limited blood flow, and you have a lot of ventilation. So a shunt means that we're not really getting oxygen or air into the alveoli as well. So that means that ventilation has gone down. So we have a low VQ. Whereas a dead space unit, we have a high VQ, which means that we have ventilation in excess of perfusion. What happens is, in the extreme cases we have here, that means we don't get gas exchange. Because look at your oxygen and CO2 here. All right, if we have a shunt unit that contains the same amount of oxygen and CO2, there's not going to be any gas exchange. On the flip side, dead space. In this scenario, this is an extreme, but you see that there's no blood flow going past this area. Well, how is this oxygen going to get into the bloodstream? It's not. So in both extreme examples, gas exchange stops. All right, so we're going to talk about this case in the classroom, but basically just read over this and give me what you think might be happening. So we're going to look at her values. Again, pay attention to what has changed as a result. So in other words, here's her situation, and she had resulting in an FiO2 of 21%. All right, so PEEP level or PEEP therapy was initiated. Her condition continues to deteriorate. So cardiac output started at 6, cardiac output ended at 3. We're going to talk about why that happened. All right, make sure you move on to Module 9. That's it for today, and I'll see you on Wednesday.